Pilon tibial fracture 4-3, C3.3, LCP distal tibia plate. This 46-year-old teacher injured his leg while skiing fast. The result was an intra-articular distal tibia and fibula fracture with considerable metaphyseal comminution. The CT scan shows that there's a small impaction on the tibial joint surface that was not visible on the standard radiographs. That's why the fracture is a 4-3 C3.3 fracture, according to the Miller AO classification. In other words, it's completely articular and multifragmentary. The new LCP for distal tibia fractures, which is based on the internal fixator principle, will be used. This plate is pre-contoured anatomically to the bone. On the bare bone model, the fracture has been reproduced as shown here. It's to be reduced and stabilized according to classic AO principles. This means that the articular components are reduced anatomically and fixed by interfragmentary compression before the plate is applied as an internal fixator, bridging the metaphyseal comminution. If fractures close to a joint are stabilized with conventional non-locking screw and plate systems, there is the danger of a secondary loss of reduction due to successive loosening of individual screws in the section close to the joint. The main feature of the internal fixator principle is the locking head screws, which provide angular stability. Upon loading, the screws that are anchored in the plate do not loosen or pull out, and thereby prevent secondary deformity or collapse. To insert the lag screw, the 2.5 mm and 3.5 mm drills, the 3.5 mm tap, the 3.5 2.5 double drill guide, the depth gauge, and the small hexagonal screwdriver are required. To insert the locking head screw, the following instruments are available: the 3.5 LCP drill sleeve, the 2.8 mm drill, the depth gauge, the screwdriver shaft, the torque limiter, and the handle. The patient is placed in the supine position with a pad under his buttock to slightly rotate the leg internally. The leg is elevated or placed on a square cushion. A tourniquet is always applied, but only inflated if there's severe bleeding. Wound healing would be safer if this demanding and often prolonged surgery was done without a tourniquet. The ipsilateral crest should be prepped in case a cancellous autograft is needed. As the first step, the simple fracture of the fibula is reduced and fixed. By doing so, the displaced anterolateral fragment of the tibia will be reduced indirectly due to the usually intact anterior syndesmotic ligaments. A slight twist to the forceps can correct the length. First, a 3.5 mm lag screw is introduced in the AP direction. The near cortex is drilled with the 3.5 mm drill bit and the appropriate drill guide. The far cortex is drilled with the 2.5 mm drill, and the length is measured with the depth gauge. After cutting the thread with the 3.5 mm tap, the screw is inserted. The reduction forceps is now removed. Next, a 5-hole titanium 1/3 tubular plate is placed over the fibula and held with the forceps. The plate is fixed with 4 standard 3.5 mm cortex screws using the conventional technique. After exposing the distal tibia and ankle joint through an anteromedial incision, the articular impaction is inspected. Depending on the extent of the articular defect as previously seen on the CT scan, the small piece of cartilage is either reduced or removed. The large anterolateral fragment is now anatomically reduced. It's held in place with the large pointed reduction forceps and a K-wire. In order to limit the exposure, it may be necessary to use a small additional stab wound to place the clamp and insert the screw from an anterolateral direction. After having checked the precision of the reduction, a 3.5 mm Cortex lag screw with washer is inserted to fix the fragment by interfragmentary compression. As an alternative to the Cortex screw, which must be over-drilled, a 4 mm cancellous screw could be used, although it's somewhat weaker. The reduction forceps is removed. After verifying the overall axial alignment, the pre-contoured distal tibia LCP is introduced by sliding it along the medial aspect of the tibia. To make this placement easier, a bending pin is screwed into the most distal plate hole. With the conventional method, using standard screws, inaccurate bending of the plate inevitably leads to loss of primary reduction because the bone is drawn to the plate. This disadvantage does not arise if an LCP with locking head screws is used. This plate does not have to be pre-shaped absolutely anatomically. In addition, the plate is not pressed against the bone, which prevents any damage to the periosteum. Once inserted, the plate is preliminarily held in place with a K-wire at each end. In the clinical situation, the correct overall alignment of the joint block and diaphysis is checked under image intensification, as indirect reduction of the metaphyseal comminution is used. If the reduction, including rotation, is correct, the bending pin is removed. Only one AP lag screw is holding the joint block together, so the first screw to be introduced through the plate is another 3.5 mm Cortex lag screw. It's aimed from posteromedial to anterolateral. The 2.5 mm drill is used first, and the hole is over-drilled with the 3.5 mm drill. After measuring the length and tapping the far cortex, the 3.5 mm screw is introduced. The distal K-wires are removed. To provide angular stability, the next screws to be inserted are the locking head screws. To guarantee that they are placed correctly, the drill guide is gently screwed into the selected plate hole. Due to the larger core diameter of these screws, a 2.8 mm drill bit is used. The guide is removed and the length is measured, although locking head screws do not necessarily have to penetrate the far cortex. The 3.5 mm green locking head screw is inserted, first with the power drive, but it's not fully driven home. The final few turns and the actual locking must be done by hand with the torque-limiting screwdriver to prevent any over-tightening or jamming of the screw. A slight click indicates the limit of the torque. The second locking head screw is added to complete the distal fixation. Through a short stab incision, the drill sleeve is introduced into the selected hole to fix the plate to the diaphysis with a bicortical locking head screw. Again, the self-tapping screw is introduced with the power drive. The final turns are done by hand, using the torque-limiting screwdriver. A short monocortical locking head screw is placed into the long spike of the proximal main fragment. After 2 more screws are introduced into the diaphysis, the proximal K-wire is removed. In case the large lateral fragment is still significantly displaced, a regular lag screw can be used to approximate it, but the fragment cannot be expected to fit anatomically. Force should not be used to pull the fragment, since that could weaken the purchase of the locking head screws and is contrary to the internal fixator principle. The fixation is now finished. This particular fracture was treated by Dr. Christoph Sommer before the special distal tibia LCP became available. Instead, Dr. Sommer used a regular LCP according to the same steps and principles. The clinical follow-up clearly shows that metaphyseal comminution does not require exact reconstruction in order to heal, provided it's not exposed or greatly manipulated during surgery.